Final lecture for this week is on hemodynamic monitoring in transport. And hemodynamic monitoring in the cardiovascular system, that's essentially a course in and of itself. So to truncate it down into a 40 or 45 minute virtual lecture is it proved to be a lot harder than I thought it would be. So bear with me because what I'm going to try to do is give you as much information in like as easy of explanations as I can to help you as you're taking care of patients who have invasive monitoring in place, so that you can know what you're looking at and how to troubleshoot it. So hemodynamic monitoring refers to the assessment of blood flow, pressure, cardiac performance, and tissue perfusion in order to determine whether oxygen delivery is adequate. The core concept is that organ injury from shock begins before blood pressure collapses completely. So earlier indicators are needed, and are more important than just your vital signs alone. So heart rate, blood pressure, skin findings, urine output, mentation, lactate, and invasive pressure measurements all provide pieces of the same puzzle. Modern transport medicine depends on integrating these values over time rather than reacting to one isolated number. This slide here establishes that there's no single variable, including blood pressure, that can fully define perfusion states. Instead, taking a big picture approach can help, especially if you utilize trending over time. In order to be able to understand hemodynamic monitoring in general, you should have a pretty solid foundation on the cardiovascular anatomy. So let's take just a minute or two to kind of refresh some things. So the right side of the heart receives venous blood and pumps against the low resistance pulmonary circuit, while the left side pumps oxygenated blood into the high resistance systemic circulation. Valve function matters because incompetent valves can alter the pressure transmission and flow patterns, which affects how waveforms and preload measurements are interpreted. Coronary perfusion primarily occurs during diastole, which is why low diastolic pressure can be especially harmful in patients with ischemia. Um, so this anatomical review kind of lays the groundwork for understanding why right-sided and left-sided pressures are not interchangeable. Taking a look at our little picture here, the heart, of course, lies beneath the sternum. Two-thirds of it on the left side of the mid-sternal line, one-third on the right. The cardiac valves, so your atrioventricular or the mitral tricuspid valve, that prevents backflow between the heart chambers. The semilunar valve, also the aortic or pulmonic valve, those prevent backflow from arteries. The heart is a biventricular system. The right side operates at lower pressures than the left. Coronary arteries supply the heart with oxygen. The heart receives its own blood supply primarily during diastole. Blood returns via the inferior and superior vena cava, mixing in the right atrium before crossing over the tricuspid valve into the right ventricle. Understanding the blood flow through the heart is very important when you have a patient who's on hemodynamic monitoring, so that you can understand the values and how they differ, and the waveforms and the actual purpose of each of the lines. Let's take a closer look at the cardiac cycle and its phases. The cardiac cycle is the sequence of filling, contraction, ejection, and relaxation that generates every pressure waveform seen on the monitor. Atrial systole contributes the final portion of ventricular filling. Isovolumetric contraction produces a rapid rise in pressure before the semilunar valves open. Ventricular ejection creates a systolic flow into the pulmonary artery and the aorta, and isovolumetric relaxation begins after valve closure, and ventricle filling continues during diastole. Tachycardia shortens diastole disproportionately. So your shock patients are at a greater risk for these things, which tachycardia also reduces ventricular filling and coronary perfusion. This is why fast heart rates can worsen hemodynamics, even if the blood pressure appears acceptable on the monitor. Moving on to cardiac output, stroke volume, and heart rate. Cardiac output is determined by the stroke volume times the heart rate. Stroke volume itself depends on preload, afterload, and contractility of the heart. An increase in heart rate can increase cardiac output only up to a point. Beyond that point, filling time becomes too short and stroke volume begins to actually fall. Bradycardia can also reduce output by decreasing the number of forward flow events per minute. This concept is really important because treatment of low cardiac output begins by deciding whether the primary problem is the rate, or the volume, or the vascular resistance, or the myocardial pump strength itself. A normal cardiac output in an adult is typically around 4 to 8 liters per minute. Less volume equates to less cardiac output, more volume to more cardiac output. If you have a decreased cardiac output, and there are many different ways that can occur, that always equates to a decreased perfusion to the body. So whenever the body or the tissues have decreased perfusion, then patients are at risk of a decreased level of consciousness. The lungs sound coarse or wet due to backflow of fluid. Patients are often short of breath. The skin becomes cold and clammy, and you'll also find weak peripheral pulses compared to what you're used to. Um, so take these three in the diagram here. Here are the three definitions. So stroke volume, yeah. So that is the amount of blood pumped out of the ventricle with each beat or contraction. Contractility of the heart is the force or strength of contraction of the heart muscle itself. And then ejection fraction is the percentage of blood that's expelled from the left ventricle with every contraction. Usually, a normal EF is around 50 to 70%, far less in cardiopulmonary compromised patients. Um, Preload versus afterload, we'll get into that more in just a minute. But preload is the amount of blood returned to the right side of the heart at the end of diastole. Afterload is the pressure that the left ventricle has to pump against. So the resistance that it has to overcome in order to circulate blood. Let's talk a little more in depth about preload, afterload, and contractility. Preload is related to the Frank-Starling law. So preload describes the ventricular stretch at the end of diastole and is often estimated with filling pressures such as CVP or central venous pressure on the right side, and then wedge pressure On the left side, wedge pressure, PCWP, that's pulmonary capillary wedge pressure, that is on the left side. The Frank-Starling relationship explains that greater filling generally increases contraction strength up to an optimal point. Beyond that point, further volume does not improve output and actually may worsen cardiac congestion. At low pressure, low output state, that suggests inadequate filling, whereas an elevated filling pressure with poor output suggests a pump failure or impaired compliance or some sort of obstructive pathology. This is why preload values must always be interpreted together with the clinical picture and the patient's response to the treatment. So a patient with low cardiac output and low CVP, they're likely volume depleted. Patients with high CVP may indicate the RV overload or poor compliance. Contrast that with afterload. Afterload is the resistance that the ventricle has to overcome in order to eject blood. On the left side, SVR or systemic vascular resistance is the main practical expression of afterload. On the right side, PVR or pulmonary vascular resistance plays a similar role. Contractility of the heart refers to the intrinsic force of myocardial contraction independent of preload. A weak ventricle may fail even when preload is adequate, while an excessive afterload state can reduce forward flow despite normal contractility. Understanding the difference between these two concepts can help to explain why some patients need vasodilation, some need vasopressors, and others need inotropes. Contractility also is influenced by muscle health, by the autonomic nervous system, by the patient's metabolic state, and also by ions like calcium, sodium, and potassium, and pharmacologic agents, and the heart rate. In terms of drugs, your positive inotropes, those include dopamine, dobutamine, milrinone, epinephrine, calcium, and digoxin. The negative inotropes, those are your beta blockers, your calcium channel blockers, quinidine, and procainamide. So looking at our little illustration here, preload, again, is the volume of blood in the ventricles at the end of diastole, so the end diastolic pressure. Preload is increased in hypervolemia, when there's too much volume, in regurgitation of the heart valves, and also in heart failure. Afterload is the resistance that the left ventricle has to overcome in order to circulate blood. Afterload is increased in hypertension and vasoconstriction. Increased afterload equates to increased cardiac output. Switch gears for a second to blood pressure monitoring. So blood pressure can be measured both non-invasively and invasively, but the method affects the quality of information that you get. Intermittent cuff blood pressure gives you useful trend data, but it might miss rapid changes and may be inaccurate in patients who are vasoconstricted, obese, or have heart arrhythmias. A Doppler can identify systolic pressure when the oscillometric cuffs fail, but an art line or an arterial line that provides a continuous beat-to-beat pressure and allows waveform analysis, making it far superior for unstable patients receiving vasoactive infusions. The major point of this slide is that mean arterial pressure is often the most clinically useful blood pressure target because it best reflects organ perfusion pressure. So having that art line in place is very beneficial. So if you have a patient with an art line in a transport, you've got a wealth of information and data that you can utilize if you know what you're looking for. We'll begin with art lines, and this kind of piggybacks off of the invasive line lecture that was prior to this one. So let's take a little bit of a deeper dive into this. Arterial lines are indicated when continuous pressure monitoring or frequent arterial blood sampling is needed. The radial site is common because it's relatively accessible and usually has a high collateral flow through the ulnar artery. However, all arterial cannulation carries risks such as thrombosis or bruising, ischemia, bleeding, infection, embolization, so emboli, and waveform artifacts once it's in. Um, in air medical transport, air must be removed from the tubing and pressure bags because expansion at altitude can worsen artifact and create some pretty significant safety risks. Um, Arterial line management is not passive. Accuracy and safety depend on careful setup and monitoring. Indications for art lines, there's a lot of them, but anytime you need continuous blood pressure monitoring for patients in shock, and patients who are receiving vasoactive or antihypertensive drugs or infusions, or patients who need repeat or frequent arterial blood gases. Besides the radial site, which is most common, art lines are also inserted femorally, brachially, in the dorsalis pedis. Always do an Allen test, which assesses the ulnar collateral flow before a radial cannulation, just like you would do before drawing in arterial blood gas. Um, Contraindications, there aren't a ton, but it's kind of site dependent. So if there's ischemia in the extremity that you're looking to cannulate, if there's an infection or bruising at the site, if the patient has Raynaud disease, or if the patient has a prior vascular surgery at the site, those are definitely contraindications. Sorry, my kids didn't know that I was recording. um, so yeah, we went through the complications and also the flight considerations. Very important to get all the air out from the pressure bags and the tubing before you ascend. When you have a patient with an art line in, the waveform analysis and interpretation is really important. So take a look at the little diagram here. Here's the normal art line waveform versus what they term overdamped and underdamped, and I'll go over what those mean. But if you have a visual to look at, it might make things a little easier to understand. Um, but the arterial waveform itself contains physiologic information beyond the displayed systolic and diastolic numbers. A rapid upstroke represents ventricular ejection. The dicrotic notch, or that little notch on the descending portion of the waveform, that represents aortic valve closure. Diastolic runoff reflects the peripheral vascular tone and the arterial compliance. So if you've got in the middle there an overdamped tracing, that often results from a clot or an air bubble or a kink in the line or some compliant tubing. And that can actually falsely lower the systolic pressure while elevating the diastolic pressure. So be on the lookout for a shape like that when it's overdamped. On the right, an underdamped tracing that exaggerates systolic pressure and creates excessive oscillation. You can see it's a little more, there's more oscillation, more jags in the waveform itself. Um, Mean arterial pressure is generally the most reliable value when the waveform quality is imperfect, but the tracing must still be interpreted in the clinical context. Always correlate the waveform quality with the clinical picture and also with the backup non-invasive blood pressure from a cuff before making any major treatment changes. Arterial lines contain a pressure reducer, and those things are pretty darn fickle. Um, Leveling and zeroing the transducer are essential because invasive pressures are only accurate when referenced to the correct physical location. The phlebostatic axis that approximates the level of the left atrium and serves as the standard reference point. If the transducer is placed too low, then the displayed pressure becomes falsely high. If the transducer is placed too high on the body, then the displayed pressure becomes falsely low. Even a small displacement introduces measurable error for these things. So because transport involves movement and loading and unloading and stretcher repositioning and altitude changes, the transducer must be reassessed repeatedly. Many abnormal values are technical errors rather than a true physiological issue. So the transducer should be positioned at the phlebostatic axis, which is right around the fourth intercostal space at the mid-axillary line, to reflect true left atrial and intracardiac pressure. To zero the transducer, and I know this image is kind of small, the transducer is here, and I don't think you can see the cursor as I'm moving it. So you open the transducer to air at the phlebostatic axis, press 0 on the monitor, and then close. That eliminates any atmospheric pressure offset. The most common source of error in hemodynamic monitoring is an incorrect transducer level. Each inch of displacement creates about 2 millimeters of mercury of an error in the measurement that is read out on the monitor. Um, Always re-level that transducer after every major patient position change and re-zero it with every 1,000-foot altitude change when you're in flight. And again, during flight, always expel all the air from the IV bags and the pressure tubing before you leave to prevent gas expansion and erroneous or messed up readings and harm to the patient. Let's switch gears and talk about central venous pressure, or CVP, specifically the measurement and interpretation. Central venous pressure reflects pressure in the thoracic vena cava and the right atrium, and it's used as a rough estimate of right ventricular preload. The waveforms on the monitor correspond to atrial contraction, tricuspid closure, and atrial filling. So atrial, right? Low CVP might suggest hypovolemia, especially when combined with signs of poor perfusion, while high CVP can suggest things like right ventricular failure, um, cardiac tamponade, pulmonary hypertension, and fluid overload. Importantly, CVP should not be treated as a standalone volume target. Its greatest usefulness to you is as a trend integrated with a bunch of other things like exam findings, lactate, urine output, ventilator settings, and blood pressure. The central venous pressure is measured through a central venous catheter, or a CVC. Central venous catheters provide central access for vasoactive medications, for rapid infusion, for CVP monitoring, blood sampling, and also for other long-term therapies. The site selection influences the risk. Your right internal jugular is the easiest to access usually. Subclavian is preferred to minimize infection risk. Femoral lines are often easier to place quickly, but they carry higher infection concerns. The types there's a number of different types of central venous catheters. There's the triple lumen, the Hickman, the Groshong, Portacath, PICC lines. Each of those has distinct transport implications for both securement and use. Complications, many. Those include pneumothorax, hemothorax, air embolism, arterial puncture, thrombosis, infection, malposition, many things that can go wrong. So your ability to stabilize it in the right place and ensure that it doesn't move is paramount in the transport setting. Transport teams need to make sure that it's secure, that it's labeled, and that the placement is accurate because catheter dislodgement or air entry can rapidly become life-threatening during movement. Pulmonary artery catheters or PACs, often called or often referred to as a Swan-Ganz catheter. That's more of a historical term, but I think it's making a comeback. But in any case, the PA catheter, it's an advanced monitoring device that passes through the right heart into the pulmonary artery. It can provide right atrial pressure, right ventricular pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, cardiac output by thermodilution, and sometimes even mixed oxygen saturation. So lots of value with your PA cath. These values can help to distinguish types of shock and guide you with your management, especially in complex cases. The catheter, though, is only as useful as your interpretation of the data that it provides. Misinterpretation is a major hazard, and mechanical complications such as arrhythmias, migration, infarction, infection, and catheter-related injury remain important concerns. Um, the priority for transport, um, while you'll rarely insert a PA cath, you should understand the pressures, waveforms, and how to safely manage it during a transport. The, the understanding of hemodynamics really rests on all of these parameters. And this table here gives you normal ranges for each, and then the clinical significance of each. So please take a look at those. Basically, it summarizes the purpose, though, is not just simple memorization of the numbers. That won't do you much good. But understanding what each value represents physiologically. So your MAP, you mean arterial pressure, that estimates the perfusion pressure, okay? The CVP estimates right-sided heart filling, so that would be your preload, okay? The PA pressures, pulmonary artery pressures, those reflect right heart and pulmonary vascular load. Um, so an elevated RV, systolic, um, leads to pulmonary hypertension or acute core pulmonale. So certainly things to watch out for. Your PCWP, or your pulmonary capillary wedge pressure, that estimates left-sided filling pressure, cardiac output, and cardiac index. That describes the pump performance, so the actual heart performance. The SVR, systemic vascular resistance, that reflects afterload. Um, so SvO2, saturation of venous O2, and ScVO2, those estimate the balance between oxygen delivery and oxygen consumption. That's a very complicated process, and it's not worth going into for this class. But as long as those terms are kind of in the back of your mind, you'll have that to work with. But when these values, all these hemodynamic parameters, when they're interpreted together, they help to identify whether shock is primarily distributive, hypovolemic, cardiogenic, or obstructive. And we'll get into the different states of shock here in just a minute. A little more on pulmonary artery and pulmonary capillary wedge pressures, specifically what they tell you. So the pulmonary artery pressure reflects the pressure the right ventricle has to generate to move blood through the pulmonary circulation. Wedge pressure is obtained when the balloon temporarily occludes a branch of the pulmonary artery, allowing downstream pressure to approximate left arterial pressure. In many patients, wedge pressure acts as a surrogate for left ventricular end diastolic pressure and therefore left-sided preload. Elevated wedge pressure strongly suggests hydrostatic congestion from left heart failure, whereas a normal wedge in a hypoxic patient points toward non-cardiogenic causes of pulmonary edema. Accurate timing at end expiration is necessary to avoid ventilatory artifact when measuring these. Um, the wedge pressure, um, normal pulmonary capillary wedge pressures are around 4 to 12 millimeters of mercury. Anytime you get above like the 18 mark, um, start thinking about left ventricular failure. Start thinking about cardiogenic pulmonary edema, um, and use that to distinguish between cardiogenic and non-cardiogenic causes. Um, when you have a patient who's got a PA cath and they're on a vent, read the wedge pressure at end expiration, so the lowest point on baseline. Um, if they're ventilated, or the highest point if they're spontaneously breathing. Um, the PA diastolic pressure closely approximates the wedge pressure in most patients, um, so that is useful when a wedge measurement is not available or you're not comfortable getting it, or um, things of that nature. So when we take a look at all the different lines that are placed and what their values kind of symbolize, um, a lot of it goes back to the measurement of cardiac output. This slide here kind of gives an illustration of um, the left ventricular stroke work, and then myocardial oxygen consumption, and how they relate to the Fick principle, which measures cardiac output. Cardiac output, um, when you measure it by thermal dilution, it uses a temperature change detected at the catheter tip after injection of a fluid bolus. The technique requires careful execution and averaging because respiratory variation and inconsistent injection can distort the result. The Fick principle, that's based on oxygen consumption and the difference between arterial and venous oxygen content. In clinical transport practice, thermodilution is far more common than a true measured Fick calculation. Um, Cardiac index is often more useful than raw cardiac output because it adjusts for body surface area and better reflects the adequacy of perfusion for the patient's size. Um, so, um, so the Fick principle where cardiac output is calculated from oxygen consumption divided by the difference between your arterial and venous O2 content. That uses assumed O2 consumption values, which may not be valid in critically ill patients, so it can be a little misleading. Um, CO index to body surface area, or the cardiac index, allows for a better comparison across different patient sizes. A cardiac index of less than 2 usually suggests a significant pump failure. Right, let's move on to SVR, stroke volume, and mixed venous O2 saturation. SVR, or systemic vascular resistance, that helps describe the degree of vasoconstriction or vasodilation in the arterial system. High SVR often appears in compensatory states such as hypovolemic or cardiogenic shock, while low SVR is typical of distributive shock. Stroke volume represents the amount of blood ejected with each beat, and it helps to show whether a low output state is due to inadequate filling, poor contractility, or excessive afterload. Mixed venous or central venous oxygen saturation, that gives you insight into the balance between oxygen delivery and tissue demand. A falling venous saturation suggests that tissues are extracting more oxygen because delivery is either inadequate or demand is increased. So, systemic vascular resistance, that takes your MAP minus your CVP divided by your cardiac output times 80 for the formula. You won't have to know like these formulas, but understanding the clinical use, that is going to certainly be beneficial. So somebody with a high systemic vascular resistance, think vasoconstriction. Vasoconstriction often as a result of cardiogenic or hypovolemic shock. Low SVR, think vasodilation. In that case, distributive shock. Um, that will help you choose between a vasopressor or a vasodilator if you have to give um, something to help treat it en route. Um, the PVR, the pulmonary vascular resistance, um, again, don't worry about the formula, but know that the PVR is elevated in pulmonary hypertension, and that's relevant for right ventricular afterload assessment, and especially if there's any consideration of ECMO or transplant. Stroke volume, that's your cardiac output divided by your heart rate times 1,000. Usually it's around 60 to 100 mLs per beat. Um, your stroke volume decreases in most forms of shock, and then is improved by optimizing preload, afterload, and contractility. All right, let's get into the four different types of shock and how they relate to hemodynamics and critical, invasive lines in these very critical patients. So let's start with hypovolemic shock. Hypovolemic shock is characterized by inadequate circulating volume. So as preload falls, stroke volume and cardiac output also fall. The body compensates by increasing the heart rate, and then, as a result, the systemic vascular resistance in attempt to maintain blood pressure and perfusion. Clinically, this produces tachycardia, cool, clammy skin, a narrow pulse pressure, delayed capillary refill, oliguria, and altered mentation. The major treatment principle is restoration of intravascular volume while controlling the source of loss. So hemodynamic monitoring helps to determine whether resuscitation is improving flow or whether compensation is failing. So the causes of hypovolemic shock, many: hemorrhage, excessive diuresis, third space losses, burns, vomiting, diarrhea, any condition depleting the intravascular volume. Your hemodynamic pattern for hypovolemic shock: you've got a decreased central venous pressure from decreased preload. That leads to a decrease in stroke volume, which leads to a decrease in cardiac output. And then compensatory systemic vascular resistance increases and heart rate increases in order to try to maintain that mean arterial pressure. Um, mean atrial pressure. Got the respiratory on the brain. Your map. Nah. Oh my gosh. Um, our map is mean airway pressure. So all the mnemonics are, they all just kind of rattle around in the head. Clinical signs, we talked about that. Transport management, so restoration of volume, crystalloid, blood products, anything to replace the depleted volume loss. But always important to identify and control the source, um, and only use vasopressors as a bridge if the map is critically low. Um, One thing also to keep in mind is to try to avoid over resuscitation with regards to fluid. Target a map of greater than or equal to 65. Um, Clearing lactate, and improving end organ signs rather than just a fixed CVP value. Cardiogenic shock, that's a pump failure state in which the ventricle cannot generate enough forward flow to meet the metabolic demand. In that case, the cardiac output falls, while the filling pressures, such as the CVP and the wedge pressure, often rise because blood backs up behind the failing pump. Systemic vascular resistance, or SVR, that increases as a compensatory response. Pulmonary edema, cool extremities, hypotension, poor end organ perfusion, all those things are common in cardiogenic shock. This hemodynamic pattern is crucial because treatment differs from hypovolemia. Aggressive fluid can worsen congestion, while inotropes, vasopressors, afterload reduction, and mechanical support may be more appropriate. Um, Cardiogenic shock is often caused by an MI, heart attack, myocardial infarction, also cardiomyopathy, arrhythmias, mechanical abnormalities, um, post cardiac surgery, a massive PE. And the hemodynamic pattern, as it differs from hypovolemic shock, you've got a decrease in cardiac output from the heart, from the pump failure. And as a result, you've got increased SVR, increased CVP, increased wedge pressure, all because of that backup congestion. And as a result, pulmonary edema is very common. Clinical signs: um, cool extremities, hypotension, pulmonary crackles and edema, frothy sputum, an elevated JVP, and some dyspnea. As far as management for cardiogenic shock, um, medications like inotropes, like dobutamine, to improve the cardiac output, careful vasopressor use like norepinephrine to maintain MAP, and then diuretics or nitrates to reduce congestion, but avoid aggressive fluid loading. An intra aortic balloon pump might be in place. Don't discontinue that during transport, um, unless you have cardiology guidance. But um, we'll get into the balloon pump here in just a second too. Distributive shock. So distributive shock is defined by a profound vasodilation and a maldistribution of blood flow. So early septic shock may have a normal or even high cardiac output, but the vascular container is so dilated that the perfusion pressure remains inadequate. Skin may be initially warm or flushed rather than cool. Over time, you'll see myocardial depression that can develop, and cardiac output might fall. This explains why blood pressure can remain unstable despite having apparent flow. The primary hemodynamic hallmark for distributed shock is low SVR, low systemic vascular resistance, and treatment centers on fluids, vasopressors, and correction of the underlying cause, such as infection or anaphylaxis. Um, so distributed shock is kind of an umbrella term. It includes septic shock, systemic inflammatory response, toxic shock, anaphylaxis, neurogenic shock, and certain poisonings as well. The most common mechanism, the identifying factor, that's massive vasodilation. That vasodilation decreases the SVR, which decreases the MAP. The CO itself might be normal or even elevated early on, but then it falls as the heart starts to get tired, and then you run into some major issues. Clinical signs: warm, flushed skin, early in sepsis, tachycardia, hypotension, a widened pulse pressure in early distributive states, and then transport management. Fluid resuscitation, typically 30 mLs per kilogram in crystalloid for sepsis as a starting point. Vasopressors with norepi as a first line medication for refractory hypotension. But in any case, treat the underlying cause. In anaphylaxis, epinephrine, either IM or IV, that's the primary therapy. Vasopressors can be used for refractory cases, and bronchodilators as adjuncts that won't really do anything unless they have an underlying obstructive disease, pulmonary disease. Finally, we've got obstructive shock. Obstructive shock occurs when mechanical barriers prevent adequate cardiac filling or forward flow. Cardiac tamponade as a cause. Cardiac tamponade compresses the heart and impairs diastolic filling. A massive PE can cause it as well. That sharply increases the right ventricular afterload and reduces left-sided filling. And then finally, we got tension pneumothorax, which increases the intrathoracic pressure and impedes venous return as well. In all of these states, these three being the more common causes of obstructive shock, the circulation may fail despite a structurally normal myocardium and adequate blood volume. The essential teaching point then is that these forms of shock are not corrected simply by adding fluid or vasopressors. The actual obstruction should be relieved um, before you'll see any true improvement. All right, so heart failure and the intra-aortic balloon pump, or the IABP. Um, In heart failure, the reduced forward flow lowers oxygen delivery, the DO2, while compensatory vasoconstriction raises afterload and increases myocardial oxygen demand, creating a vicious cycle. The balloon pump um, that interrupts this cycle by inflating during diastole to improve coronary perfusion and deflating just before systole to reduce afterload. As a result, myocardial oxygen supply improves while ventricular workload decreases. So it's a twofer. Um, the device doesn't replace cardiac output the way a ventricular assist device does, but it can stabilize selected patients as a bridge to more definitive therapy. Um, the myocardial oxygen supply must balance demand. Um, Acute MIs or ischemia, those tip the balance toward the supply failure. Um, Left ventricular failure, that creates a self-worsening cycle. That's that repeated cycle. So a decrease in cardiac output leads to an increase in SVR to try to compensate, which leads to an increase in myocardial oxygen demand, which furthers the ischemia because there's not it's not working. Sorry. The balloon pump though, that provides kind of a counter pulse. So it inflates during diastole to increase coronary perfusion pressure. It deflates during systole to reduce left ventricular afterload. And yeah, transporting it with the balloon pump, I can't even imagine, honestly. Like, they're intimidating enough in the ICUs. Um, to have one in the back of a bus or God forbid on a flight, man, that you know that's not for me. But more power to you guys. But transport with it when you're transporting with it. Don't ever disconnect it. Don't ever stop it. Just set it and forget it, and make sure that the timing is on and that there's adequate helium in the reservoir, and there's secure arterial access, and keep it as stable as you can as possible. There are some newer hemodynamic monitoring methods that aim to provide some clinically useful information with less invasiveness than a PA catheter and others of that nature. Um, Certain things like pulse pressure variation and stroke volume variation can suggest preload responsiveness in carefully selected patients who are on ventilators. Ultrasound is one. Ultrasound provides a rapid bedside assessment of ventricular function and volume status and some causes of obstructive shock. Arterial waveform analysis devices are pretty neat. They can estimate cardiac output continuously from existing lines. Um, these tools, yeah, they can supplement, but they don't replace your clinical assessment, the MAP monitoring, lactate trends, and all of the other things that make up the clinical picture for a critical care patient in transport. One of the biggest challenges that you'll face is keeping these lines aseptic, managing the lines, and preventing infection. Infection prevention and line safety are major parts of hemodynamic monitoring because every invasive device creates a pathway for complications. Strict asepsis during insertion and every subsequent access reduces catheter-related bloodstream infection. Dressings, securement, port cleaning, minimizing unnecessary manipulation, all of those things matter. In transport, it's especially important because the vibration, the movement, the environmental constraints all increase the chance of contamination or accidental dislodgement. Hemodynamic lines should be viewed not only as a monitoring tool, but also as a potential source of significant harm if it's not managed carefully. This table here kind of integrates some hemodynamic data um, into a clinical framework or picture. So 5 steps, questions that you can ask, and then data sources where you can derive the information from. Um, Number one, is perfusion adequate? Always ensure that perfusion is um, like at the forefront of your mind for patients in these states. So is the patient moving towards shock? What's a clinical picture? For that, look at the heart rate, look at the map, their mental status, skin perfusion, urine output, lactate. And then ask yourself, what's the cardiac output state? Is the heart pumping enough? Well, take a look at the heart rate, the stroke volume, the COCI ratio, if you have it, if there's a pulmonary artery catheter. Look at your trending maps. See if they have and what kind of response to any kind of fluid administration or inotropic administration. And then go a little deeper and like, all right, what's the preload? Is there enough volume in the circuit? Is there enough volume in you know, in the heart? Um, with that, look at your pressures. So your CVP, your wedge pressure, the IVC on echo if there's one available. Um, Look for clinical volume signs. And then after you determine that, think, all right, what's the afterload? Is the systemic or the pulmonary resistance abnormal? Well, look at your SVR, look at your pulse pressure, look and see if and what the response is to vasopressors. And then finally, what's the oxygen delivery, slash consumption balance? We're not going into O2 delivery and O2 consumption. That's way, beyond the scope of this class. But the question is, are the tissues getting enough oxygen? Well, how's their lactate? How's their O2 saturation? How's their hemoglobin? How do they present clinically on respiratory assessment? Um, Things of that nature. We're wrapping up here, and I know this is a lot of info and it's pretty dense, and I apologize. It kind of is what it is. But let's concentrate for a second on the actual considerations for transport, both flight and ground, for hemodynamic monitoring. Um, Transport adds, like it does for everything, unique complications to hemodynamic monitoring. Changes in altitude expand the gas in the tubing and the pressure bags, which can distort readings and create a myriad of different hazards. Motion and vibration create artifact. Noise makes auscultation and troubleshooting a lot more difficult. The transducers, say on an art line, those can shift out of position during loading or flight. Infusion pumps may behave differently than gravity systems under movement. Um, and transport clinicians should be able to anticipate these problems before they leave and build redundancy into the plan through alarms, setting alarms appropriately, through frequent assessment, through ensuring that the line placement is accurate and secure, and that you've got backup methods of verification if at all possible. The table here gives you normal value ranges for the different hemodynamic monitoring assessment pieces. I don't know if you'll be held to know those specifically or not, but there they are. I would argue that the things to keep in mind most are the CVP, so 2 to 6 for a norm, the MAP 70 to 105 as a norm, heart rate, of course, wedge pressure 4 to 12, cardiac output 4 to 8, cardiac index 2.2 to 4, and then your uh, PVR and SVR, and I would say the rest. I wouldn't I wouldn't think you need to know much about those, but PVR 100 to 250, and then SVR 800 to 1200 as normal ones. A quick look at troubleshooting waveforms in patients with hemodynamic lines. Waveform troubleshooting should begin with the assumption that abnormal data can be technical rather than physiologic. It's not always the patient. If you've got a loss of waveform, damping, ringing, or unexpected pressure changes, those may result from a disconnected line, a clot, tubing compliance, an air bubble, poor leveling of the transducer, or even a migration of the catheter. So having a systematic check of the entire monitoring chain prevents inappropriate treatment based on false readings. This is particularly important in transport, where a faulty invasive pressure reading can easily trigger the wrong vasopressor or the wrong fluid decision. Verification with non-invasive measurements and the overall clinical picture is absolutely essential. Let's take all of this dense information and kind of wrap it into 3 different cases, um, so you can hopefully get a picture of um, what it'll look like and what you should do. So let's start with the first one. We've got a 62-year-old male post-STEMI with cardiogenic shock. The post-MI patient here demonstrates low output, okay, with a high filling pressure and compensatory vasoconstriction. So that patient post-STEMI cardiogenic shock, they're going to have low cardiac output. As a result of the low cardiac output, they're going to have a high SVR, probably a high CVP, a high wedge pressure. They might have cold extremities. They could have some pulmonary edema developing. Um, your priorities during transport should be inotropes like dobutamine, careful pressure administration like norepi. Always avoid fluid overload. If they've got a balloon pump, maintain it and target a MAP of greater than or equal to 65. The middle patient, 38-year-old female with septic shock. Um, the septic shock patient illustrates a low SPR with relative or absolute vasodilatory failure. Um, so, 38-year-old female septic shock, she's going to have a low SVR, will probably have normal or even an increased cardiac output at first, but then after time, a decreased MAP, warm skin, tachycardia, and your priorities as transport. Clinicians should be a norepi vasopressor. Um, consider like a 30 ml per kilogram crystalloid bolus. Reassess their lactate, and then ensure that they've got some antibiotics on board. And then the third case here, a 28-year-old trauma patient in hemorrhagic shock. Um, they represent low preload, low cardiac output, and a high compensatory SVR. So the CVP would be down, the CO's down, um, and the SVR is elevated. All of that leads to tachycardia, hypotension, and a narrow pulse pressure. Um, in this case, blood products, tourniquet, pressure, um, and allowing for uh, lower maps permissibly en route can assist with that. The purpose of comparing these three cases real quick, side by side, is just to show you that hypotension alone does not reveal the underlying mechanism of what's going on with the patient. Hemodynamic interpretation guides, they're very different treatments for each scenario. Are you guys tired of my voice yet? You can say yes. I'll No hard feelings. All right, last slide. Summarizing the major teaching points from this lecture. So, cardiac output is determined by the heart rate and the stroke volume, and the stroke volume depends on preload, afterload, and contractility of the heart. Invasive lines and monitors provide useful information only when they're leveled correctly, when they're interpreted accurately, and when they're integrated with the physical exam of the patient that you actually perform. Um, Different forms of shock produce characteristic hemodynamic signatures that help guide the therapy that you provide. The overall lesson is that hemodynamic monitoring is most powerful when it's used to detect patterns and to follow trends and to match the treatment to physiology rather than simply relating it to numbers. Understanding the four shock patterns by their hemodynamic instability and how to treat them is is paramount to your care for the patient en route. And then finally in transport, your systematic troubleshooting, alarm management, and keeping in mind the flight physiology. Those are all important, and you know more important than just memorizing the normal values of some of those things. That was a long week. That was a long week. And honestly, like if you got through all of my videos, I mean, let me know. Prove it somehow. I'll, I'll buy you a beer because that was a lot. Um, Hopefully, you guys are able to retain some of it. Hopefully, it correlates with the worksheets and the quizzes and the discussion boards and the exams that you'll ultimately be given. Um, but thank you. Any questions ever? Hit me up. Shoot me an email. Um, my information's in Canvas, jramsey@kvcc.edu. Um, I'm happy to give you my cell phone. You can text me with questions or anything anytime. I look forward to seeing you guys in lab. It's so bizarre and so weird to do these lectures and just talk to my laptop screen and not know if anyone's going to even watch it or if you're going to get anything out of it or how terribly boring it may be. But it's a lot. Just a insane amount of information stuffed into 40-minute chunks and power to you guys for sticking with it. Power to you for what you do too. Um, My favorite part, and I said this in the very beginning, favorite part of being a respiratory therapist was when I was a primary transport therapist up at Helen DeVos Children's Hospital in Grand Rapids, where we did ground transports for most of the state. Even I went to Chicago a couple times, close to the UP a few times. I don't know. I just love that part of it, and so I've got mad respect for all that you guys do. So I appreciate you, and I will see you on the other side.